Assalamu alaikum. Our today's topic is lesions of spleen and thymus. Bismillahirrahmanirrahim. Congenital anomalies of spleen. First one, agenesis. Agenesis of spleen is rare and usually it is associated with situs inversus and cardiac malformations. Second anomaly is hypoplasia, which is more common than all other anomalies. Third thing is accessory spleen or spleniculi. These are also common, single or multiple in number, and they can be found at any place in the abdominal cavity. Functions of the spleen, as you know, the phagocytosis, antibody production, hematopoiesis, and sequestration. These all are the functions of the spleen. Splenomegaly. Splenomegaly causes dragging sensation in the left upper quadrant and discomfort after eating through a pressure on the stomach. Hypersplenism. It is a syndrome which is associated with splenomegaly and characterized by anemia, leukopenia, and thrombocytopenia, alone or in combination. So the condition is termed as hypersplenism. Causes of splenomegaly. The main thing here is infections, multiple infections, infectious mononucleosis, tuberculosis, typhoid, brucellosis, cytomegalovirus, syphilis, malaria, histoplasmosis, toxoplasmosis, Kala-Azar, trypanosomiasis, schistosomiasis, leishmaniasis, echinococcus. So you can notice here that bacterial, viral, and parasitic infection all may cause splenomegaly. The congestive states which are related to the portal hypertension, cirrhosis of liver, portal or splenic vein thrombosis, and cardiac failure. Lymphohematogenous disorders which may cause splenomegaly are Hodgkin's lymphoma, non-Hodgkin's lymphoma, and lymphocytic leukemia, multiple myeloma, myeloproliferative disorders, hemolytic anemia, and the immunological and inflammatory conditions like rheumatoid arthritis and SLE. Storage diseases which may cause splenomegaly are Hodgkin's disease, Niemann-Pick disease, mucopolysaccharidosis. Other miscellaneous disorders which may cause splenomegaly are amyloidosis, primary neoplasm and cyst of the spleen, and secondary neoplasm or metastatic lesions. Splenomegaly, non-specific acute splenitis. Enlargement of spleen due to blood-borne infections resulting from microbial agents and cytokines. The morphology here in non-specific acute splenitis, grossly spleen is enlarged and weight becomes 200 to 400 grams and soft in consistency. There is acute congestion of red pulp and lymphoid follicles. White and red pulp are infiltrated by inflammatory cells as neutrophils, plasma cells, and eosinophils. In case of streptococcal infection, the white pulp follicles undergo necrosis. Abscess formation is rare. Congestive splenomegaly. It results from chronic venous outflow obstruction, and the causes are either intrahepatic or extrahepatic. The extrahepatic causes both may lead to portal or splenic hypertension. Morphology here is there is marked enlargement up to 1500 grams in weight, firm in consistency, and thick and fibrous capsule formation. Red pulp involved initially and becomes fibrotic and cellular with time. There is deposition of collagen at the basement membrane of sinusoids and causing the slowing of blood. With prolonged exposure of blood elements to the macrophages leading to the excessive destruction of the cellular elements in spleen. Splenic infarcts. Occlusion of major splenic artery may result in splenic infarcts, the common lesions due to embolus occlusion. Most commonly, infarcts are due to the emboli of heart origin. The infarcts are small to large and single to multiple. And the morphology of spleen, in case of splenic infarcts, the blunt infarcts are pale, wedge-shaped and subcapsular in location, while the septic infarcts are suppurated and necrotic, and there is large depressed scars resulting after healing. The neoplasm of spleen. Benign tumors of spleen are fibroma, osteoma, chondroma, lymphangioma, hemangioma. And the malignant tumors of spleen are, the primary tumors are rare, very rare. And the secondary tumors involving spleen are myeloid, lymphoid neoplasms. Thymus. The developmental disorders of thymus are number 1, thymic hypoplasia, thymic aplasia, isolated thymic cyst, and thymic hyperplasia. Thymic hypoplasia or aplasia occurs in DiGeorge syndrome, and it is marked by severe defect in the cell-mediated immunity with variable developmental abnormalities of parathyroid gland associated with hypoparathyroidism. Second thing is isolated thymic cyst. It is rare and it is up to 4 cm in diameter, and the lining is stratified epithelium to columnar epithelium, and cyst is filled with seromucinous fluid or hemorrhagic fluid. Thymic hyperplasia. Thymic follicular hyperplasia, it is characterized by appearance of B-cell germinal centers within the thymus. And the reasons are inflammation and immunological. Immunological examples are myasthenia gravis, Graves' disease, SLE, scleroderma, and rheumatoid arthritis. Morphology here is gland is enlarged grossly. The tumors of thymus. Epithelial tumors are thymoma, other tumors are germ cell tumors, lymphoma, and carcinoids may occur in the thymus. Thymoma. The classification of thymoma. Number 1, tumors that are cytologically benign and non-invasive. Second category is the tumors that are cytologically benign but invasive in nature. And the third category, that tumors that are cytologically malignant. The tumors more commonly affecting the age above 40 years. Tumors are very rare in children, and the male to female ratio is equal. The most common site for the thymoma is anterior superior mediastinum. This is the frequent site, and the neck, thyroid, pulmonary, hilus sometimes occur or sometimes involved by the thymoma, while the posterior mediastinum is very uncommon. Morphology of the thymoma. Gross features: gray-white in color, consistency of the tumor is firm, lobulated, 15 to 20 centimeter in size. There is cystic necrosis, areas of calcification may seen or may noticed. Mostly it is capsulated, but 20 to 25% infiltrate the capsule and perithymic tissue. Microscopic features are non-invasive tumor. The very first one, benign and non-invasive. There is medullary cells or cortical cell type or cortical epithelial cells, or both cells are present in first type. The medullary cells are elongated or spindle-shaped epithelial cells, and there is infiltration with thymocytes. Second category is invasive invasive thymoma. These tumors may metastasize due to their invasive nature, and the cell type is here is cortical epithelium with abundant cytoplasm and rounded vesicular nuclei, usually mixed with thymocytes, and these are about 20 to 25% of the thymoma. And these tumors may invade the capsule and penetrate the surrounding structures. The third type is thymic carcinoma or malignant type of thymoma. It represents only 5% of the thymomas, and the grossly these are fleshy in nature, and most of them are squamous cell carcinoma, lymphoepithelioma-like carcinoma. It is the next common variety of thymus tumors, and this tumor is composed of sheets of cells with indistinct borders. 50% of these tumors are Epstein-Barr virus positive. Clinical features are symptoms due to the pressure on the mediastinal structures. Thank you so much, Beta. Any question? Question, Beta?